Good evening, everyone. We're so excited that you have joined us once again for another episode, another installment of our webinar series. Tonight, we're going to be talking all about diabetes. I have an amazing panel of experts here with me tonight. We really can't wait to get into it. Very quickly, just as we give people a moment to join, I do want to remind you of a couple exciting things that we have going on. As you know, last fall, we put out a pilot podcast from Columbia Children's Health. It is called The Stuff That Matters for Kids' Health. And we have several of our Columbia Children's Health experts on the podcast. It is really informative, really fun. We just invite you to join, take a listen, share if you like it. We also are on social media where we are sharing more and more expert advice, as well as happenings at Columbia Children's Health. So we definitely invite you to follow us there as well. It is at Kids at Columbia on Instagram, Twitter, X, I should say, Facebook, and we just hope you'll join us there. So with that, let me introduce the amazing experts I have with me tonight. First, we have Dr. Natasha Leibel. She is an associate professor of pediatrics here at Columbia. She is the director of the Pediatric Diabetes Program at the Naomi Berrie Diabetes Center. We also have Dr. Rachelle Gandica. She is an assistant professor of pediatrics here at Columbia and also part of the Naomi Berrie Diabetes Center. And last but not least, here on the screen, we have Dr. Jacqueline Lonier, who is an assistant professor of medicine at CUIMC and also part of the Naomi Berrie Diabetes Center. We're so happy that you have joined us. I'm going to stop sharing my screen so we can get right to the conversation. As you know, in the past few webinars that we have done, we've had both doctors and parents join us, which we're super grateful for. So I figured we could start maybe, Natasha, with you, defining a little bit, reminding people of what we're talking about when we say type 1 diabetes, type 2 diabetes, just to have some working definitions as we move into the meat of the conversation this evening.
Sure, absolutely. Thank you, Edith. So type 1 diabetes is an autoimmune condition that's characterized by the body's inability to produce insulin. An autoimmune disease means that your immune system attacks your own cells by mistake. In the case of type 1 diabetes, there's an attack on the beta cell of the pancreas. This is the cell in the body that makes the hormone insulin. Insulin is responsible for controlling blood sugar, and without insulin, the levels of sugar in our bloodstream will become dangerously high. Think of insulin as keys and that the cells of our body have little doors with locks. Insulin, the key, opens those locks and lets sugar in. Without any keys, the sugar is going to have nowhere to go. So the only treatment for type 1 diabetes is to give the body back insulin or the keys it is not making. We do not know why people get autoimmune diseases such as diabetes. It is fairly accepted that there is likely a genetic risk and an environmental trigger that starts the process. And it's really important to know that it is never anyone's fault that they get type 1 diabetes, and there is currently no way to prevent the disease or to cure it.
Yeah. And to ground us a little bit, I think the definitions are super helpful, of course, and we're going to be talking about both type 1 and type 2 diabetes. But I also wonder, Natasha, if you can give us a sense of the bigger picture and where we are in terms of diabetes and the numbers and how many children it affects in this country today.
Sure. So type 1 diabetes affects approximately 300,000 children under the age of 20 years in the US. There's about 1.7 million adults living with type 1. Over the last 20 years, the incidence of type 1 has increased in all age, sex, and race ethnicity groups in the US. Type 1 is increasing at about 1.9% per year in children under the age of 20. It's important to know, though, that about half the people who are diagnosed every year with type 1 diabetes, and that number is about 60,000, so about 60,000 people are diagnosed a year, are adults. It is a common misconception that type 1 is only a disease of childhood, but in fact, as I mentioned, it's quite often diagnosed in adulthood as well.
Yeah. And then what about type 2? Where are we in terms of the numbers and the trends when it comes to type 2 diabetes and specifically in children?
Sure. So I'll just start by defining type 2 as well. But type 2 results from the body's inability to respond properly to insulin. So in this case, the pancreas makes lots of insulin or those keys, but the body cells are resistant to it, causing sugar to build up in the bloodstream. So again, going back to our keys and locks, the pancreas is producing lots of keys, but the locks, think of them as being jammed and not opening. This is called insulin resistance, and it's caused by a combination of a genetic predisposition and most often being overweight or obese. As compared to type 1, where there's only insulin as the treatment, there is a multitude of treatments for type 2. Treatment always involves lifestyle changes such as diet and exercise, but there's also oral medications as well as injectable medications that can treat type 2, and you'll hear about some of these later. Sometimes insulin is also needed in type 2. Now, type 2 diabetes is really considered an epidemic. There's about 40 million people in the US who have type 2 diabetes, which is about 1 in 10 persons. And unfortunately, more and more young people, including teenagers, are being diagnosed with type 2 diabetes, and this is paralleling the rise in obesity in this country. There's been an almost 5% increase per year in the number of children under the age of 20 being diagnosed with type 2, and the number of adults living with type 2 is expected to double by 2050.
Yeah. And, I do want to transition to some of the therapies, which is, I think, of course, what piques people's interest and the reason why a lot of physicians on the line have joined us. But I want to ask you, Natasha, before we move on, and as a reminder, everyone listening, you can send us questions. We are actively monitoring the chat as well as the Q&A. So any questions you have, go ahead and send them. If we can include it in the conversation we're having at the moment, of course, we will include it, but we can also save time at the end for questions. So definitely feel free to send us those. But Natasha, the question, I guess the follow-up question I wanted to ask you is, why is type 1 diabetes on the rise? I understand why type 2 diabetes is on the rise. It mirrors, a lot of what's happening with the obesity epidemic. But why is type 1 diabetes on the rise?
Well, that's a great question. It's not really well known. I mean, autoimmune diseases as a whole are on the rise. And so I think that type 1 is, also going along with that rise. And it's really not well understood. There's been so many theories put out there, and none of them have really been proven to be true. So we don't really know. We don't really know. I think there's a lot of efforts into trying to figure out why autoimmune diseases as a whole are on the rise.
Yeah. We just had a question come into the Q&A, and it's exactly what we're going to tackle next as part of this webinar. And it's, about therapies and about medications that are available. So maybe, Jackie, we can start with you and we can focus a little bit on the classes of therapies, right? A little bit of an overview of what's available to treat type 2 diabetes.
Sure. So as Natasha mentioned, there are several different kinds of medications that we can use to treat type 2, in addition to diet and exercise being the foundation of type 2 therapy. So we have older medications like metformin, like sulfonylureas and TZDs. These have all been around for a long time, 25, 30 years. Metformin remains a first-line choice of medication for people with type 2 diabetes. We've been using it a long time. We know it's safe and effective, it's cheap, and it's readily available. It's an oral medication, and it basically works by reducing the amount of glucose that comes out of the liver. So this is for a long time been our first line medication choice for people with a new diagnosis of type 2 diabetes. And it remains so, I think, at this point, one of our first line choices. There are older medications that we're not using so much anymore that remain options, especially if cost is an issue. And these are the sulfonylureas and the TZDs. The sulfonylureas work directly on the pancreatic beta cells to promote insulin release. One of the side effects of this is that they can cause unpredictable hypoglycemia or low blood sugar, which can be problematic. TZDs work by sensitizing the tissues to insulin. So That sounds nice in theory, but unfortunately, these medications are associated with many side effects, which do limit their use for many people. We do unfortunately now have some new medications, which I think is what everyone wants to talk about. So first I'll talk about the SGLT2 inhibitors. These are medications that are orally administered and work by blocking reabsorption of glucose in the kidney. So when your blood sugar reaches a certain point, that glucose gets filtered into your urine and then you pee it out. And that's why people with uncontrolled diabetes have excess urination. So these medications prevent the excess glucose from getting reabsorbed into the blood and thereby lowering blood glucose concentrations. And we also have now GLP-1 agonists, and these are injectable type 2 diabetes medications, and they are what we call analogs of a hormone that's naturally produced in the body called GLP-1, which when produced normally in the body at usual levels, they're produced from cells in the intestine in response to meals, and they help promote insulin secretion following meals. They help promote satiety and control eating behaviors. They help you feel full. And so they're called what we call satiety hormones. So when we give them in a big dose, as we do in medication form, it enhances all of these effects, and in people with type 2 diabetes lowers blood sugar, and they also promote weight loss. So these new medications have really changed the landscape for treatment of type 2. We can now treat without causing low blood sugar. We can promote weight loss. There's really not many concerning side effects with the use of these medications. And in fact, they've been shown to have benefit in terms of cardiovascular and kidney outcomes. So for a long time, we were kind of stuck. We could treat blood sugar, but we couldn't necessarily treat the increased cardiovascular risk that's associated with type 2 diabetes. But these medications have been shown to improve cardiovascular outcomes in our patients.
Yeah. Let me ask you a couple of follow-up questions. One that came in is whether these newer medications, widely promoted as weight loss medications, but of course you just explained beautifully how they act, whether they have a role in type 1 diabetes and whether you can discuss that role, even though they're not necessarily approved for that. And Rachelle, we're going to pivot to you in a second to talk about type 1. So I leave it up to you who wants to answer this question, but whether these medications have a role in type 1 and what it is and how it's been working.
So two of these medications, semaglutide and I forgot to mention tirzepatide, which is a dual GLP-1 GIP agonist. GIP is another hormone that's like GLP-1. Both of these medications have approvals for treatment of type 2 diabetes. Under different brand names, they also both have approvals for treatment of obesity. So you can have type 1 and you can have obesity. So you can actually treat on label with these medications in somebody who has type 1 who meets criteria for the obesity indication. It's not for treatment of the blood sugar in people with type 1 diabetes, but it is approved for treatment of weight.
Yeah. And what about Jackie, treating type 2 and any, therapies that are available, treatments that are available in people who are struggling with long COVID? And do you think about those people differently? I guess would be the first part of that question.
That's a great question. I'm not sure I have a lot of experience treating people with long COVID and diabetes. I don't think it would necessarily change my approach. So I don't really have any concerns with these medications in the setting of long COVID. I would treat the diabetes as needed.
Yeah. There was a question that just came in about whether the recording will be available on YouTube. We will have this recording on YouTube after tonight's webinar. And we will have more time for questions that are coming in as we speak as well. But Rachelle, I wanted to pivot to you and talk a little bit about some of these therapies and newer therapies in children for both type 1 and type 2 diabetes.
Sure. So type 1 diabetes, as Natasha had said, it's lifelong insulin injection therapy. That is the basis of what these patients need. And insulin has to be given into the subcutaneous space. So we use very small needles that are less than 8 millimeters. And the dosing is incredibly precise. We educate all of our newly diagnosed families how to check blood sugars, how to count carbohydrates. And so then that dose that they're going to inject, and they must inject before they eat, really depends on what their blood sugar or blood glucose level is before they're about to eat, and what the number of grams of carbohydrates they're about to eat. So you can imagine in young patients, this is challenging to know, first of all, how much they're going to eat and to figure all the timing of that out. But the new technology has made both checking sugar levels easier, and we'll get into that a little bit later with the glucose sensors and the different types, and also giving insulin. It's made that easier as well with the insulin pumps. And so finally, we actually have devices now that are called closed loop systems. So the loop is the glucose sensing and the insulin delivery they talk to each other. So when the sensor detects that the glucose is rising, the insulin pump reacts by giving more insulin, and then vice versa. If the glucose is dropping, the insulin pump can give less insulin or even pause the insulin delivery for a brief period of time. And so using these devices that are so sophisticated and are really covered by all forms of insurance, thank goodness, helps to improve glucose levels. And this translates to better both short-term outcomes, so less hospitalizations, less diabetic ketoacidosis, and also better long-term outcomes, so less diabetes complications in the future. I was going to mention a bit about type 2 therapy in children specifically, because I wanted to talk just briefly about a trial, the TODAY trial, which is well known. TODAY stood for Treatment Options in Type 2 Diabetes, Adolescents and Youth. And it was a huge trial, 700 participants, and there were 13 diabetes centers across the country. And we were actually the Berrie Center, were one of the centers that had participants. And basically we wanted to learn, when children and teens are diagnosed with type 2 diabetes, what are the long-term outcomes? And so everyone gets started on metformin therapy. And what we learned is that after only about 4 years, half of those patients needed to start insulin injections, half of them after 4 years. And in terms of the long-term complications, the outcomes are really staggering and very sobering. After about 15 years of having type 2 diabetes that was diagnosed as a teen or young adult, 80% of these individuals have at least one complication of diabetes. And so this trial was conducted before a lot of the newer therapies that Jackie was just talking about came around. And so we are so thankful that we have options now, and we really should be aggressively treating these patients with the GLP-1 agonists, or now even SGLT2 inhibitors are also approved for children. So we have more things to use, and we should be using them early to avoid those outcomes.
Yeah. And Rachelle, let me ask you a follow-up question. As primary care, I'm a primary care pediatrician. I don't know if I said that at the beginning. I apologize if I didn't, but I am a primary care pediatrician, and it's been tough to get insurance to cover some of these medications, especially for patients who suffer and struggle with severe obesity. And I wonder how it's playing out for you guys and children. Is it different once they're diagnosed with diabetes? Is it easier to get coverage? Like, how is this playing out? And are you actually able to get your patients access to these, newer kind of medications?
So if they carry a diagnosis of type 2 diabetes, we get these medications covered.
Yeah.
The tricky thing is similar to the question asking about, can you use GLP-1 agonists in a type 1? That is hard, because I have had many patients that are rejected. Their insurance rejects payment of the GLP-1 agonists. They are obese. Their diagnosis is type 1 diabetes. It's not type 2 diabetes. And we get a lot of rejections, and it's frustrating, very, very frustrating.
Yeah. Yeah. Especially when it can make a difference, right? In
Yes.
these outcomes that you're talking about.
Yeah.
So let's tackle, I definitely want to move towards talking, because there's a lot of exciting things happening in the realm of innovation and therapies that are coming down the pipeline. But I do want to stop for a second and answer a few of the questions that have come in. And maybe Natasha, I can go to you for this one. In terms of differentiating type 1 diabetes from type 2 diabetes later on in life, how do you make that differentiation when it's not a clear, childhood onset type 1? And maybe Jackie, you can weigh in as well.
So, well, we pride ourselves here at the Berrie Center at being able to really pinpoint what kind of diabetes someone has. And there's a couple ways to do that. So sometimes the cases are very clear cut. If a child presents, under the age of 10 and is fairly thin and has classic symptoms of being thirsty and losing weight and so forth, we're going to be pretty sure it's type 1. But we can always draw these protein markers called autoantibodies. And these autoantibodies are present in people who have type 1 diabetes. There's 5 of them that we can check for, and I'll talk more about these later. But so we can measure those. We can also measure how much insulin someone is making. And in people with type 1, by and large, they're going to be making almost none, very little, and their blood sugar will be very high. In a teenager who has a strong family history of type 2 diabetes, is overweight, and maybe has a more insidious onset of their symptoms, we would most likely still draw these autoantibodies just to be sure, but we'll be pretty sure that that's a type 2. And there are other rarer forms. We call these atypical diabetes that Rachelle's going to talk about a little bit as well. But we really are pretty good at making the proper diagnosis and definition. One complicating factor, and I'm going to bring this back to something Jackie said before, people with type 1 can also be overweight or obese. And then you have the combination of not making insulin, having to give it back to yourself, but also being kind of resistant to it because of the fact that you're overweight. And so in very severe cases like that, that's when we would consider using the GLP-1s.
Yeah. Jackie, a question that came in that I think you may be able to help us tackle. Once you start insulin for the treatment of type 2 diabetes, do you require insulin for life? Is this something you can sort of go back from once you've required insulin? And when it comes to diet and exercise, is there a specific type of exercise that is best suited for controlling diabetes?
Sure. So I think what's important to understand about type 2 diabetes is that it's what we say very heterogeneous, meaning it's very different from person to person. So some people will do fine with diet and might have a diagnosis of diabetes, but do fine with just diet and exercise for many years. Some people will need a very low dose of medication, and some people will progress pretty quickly to requiring intensification of their regimen and even insulin or multiple daily injections of insulin, the way somebody with type 1 does. So insulin is not addictive in the setting of type 2 diabetes. There's no dependence that you develop upon it. But some people do require it to maintain their glucose control. So it's another tool that we have to treat type 2 and achieve glucose targets. That's the way I think of it. I don't have a specific diet and exercise regimen that I recommend. We get asked these questions all the time, but I recommend following a normal, healthy, balanced diet. Everything in moderation, moderate carbs, moderate fat. Exercise recommendations are the same for everybody across the general population. So a good amount of moderate exercise per week, which can be walking, that counts. It doesn't have to be, intense exercise at the gym, but staying generally active and following generally healthy habits.
Yeah, I love that. And we just had a question come in that is actually exactly where we were going to go next in the flow of this webinar. As we were preparing, and I truthfully did not know very much about this, but as we were preparing for this, Natasha, you pointed out that there are ways that immunotherapy is currently being used to delay the onset of type 1 diabetes. Again, immunotherapy being used to delay the onset of type 1 diabetes. And I wonder if you can explain how that works for our audience.
Right. So this is actually a really exciting new development in type 1. So as I discussed before, type 1 diabetes occurs when the immune system attacks the beta cell of the pancreas. And we can tell that this process is going on by measuring those 5 different protein markers, the autoantibodies that I just mentioned in the blood. So the definition of type 1 diabetes is defined by 3 progressive stages. So stage 1, type 1 diabetes, is when there's 2 or more autoantibodies present, but the blood sugar is in the normal range. Stage 2 is when 2 or more autoantibodies are present, but now the blood sugars are beginning to go outside of the normal range. And stage 3 diabetes, type 1 diabetes, is when the blood sugars have reached the levels we would consider in the diabetes range and insulin is now required. So over the past few decades, there have been numerous trials looking at different immune modulating drugs to try to slow this progression. And actually now there is an FDA approved medication on the market, which is called teplizumab. The brand name is Tzield, and it's approved for ages 8 years and older. And in clinical trials, teplizumab significantly delayed the time from stage 2 to stage 3 diabetes by 25 months. So people who received this drug developed stage 3 on average 4 years after receiving the treatment, which is a 2-week daily IV infusion, versus those who did not receive it and developed stage 3 in 2 years. And this drug works by modulating the immune attack on the beta cells. And we encourage all our first-degree family members of our patients, or any patients in the community who have a first-degree family member with type 1, to consider getting screened for these autoantibodies, because we now possibly have a way to prolong this period before insulin is needed. And there are also other clinical trials ongoing as well for persons at high risk of type 1. So I would also just like to mention, because we commonly get asked this question, that the risk in the general population of developing type 1 over your lifetime is about 1 in 300, and this risk is going to increase to 1 in 15 with a first-degree family member.
Yeah, yeah. And someone just asked us that on the chat. So I really appreciate you tackling that. And it really, I mean, it's an exciting time to be able, of course, you can't cure it. As you mentioned, it is an autoimmune disorder, but to be able to delay some of the symptoms and the progression of the illness itself, it's very, very exciting. Jackie, I wonder if you can tell us more about ongoing clinical trials, because there's a lot that you all do, and we'd love to learn.
Sure. So we are a site for a research consortium called TrialNet. And this is the research group that produced the study that Natasha just referenced that led to the approval of teplizumab. So the goal of the TrialNet consortium is to identify therapies that can delay or prevent the onset of type 1 diabetes. A lot of the ongoing work involves identifying people who have antibodies or stage 1 or stage 2 type 1 diabetes. And we do this here every day at our center. We ask our the family members of our patients with type 1 diabetes if they're interested in being screened through TrialNet. So they have a blood draw, and through TrialNet without any fee, they can learn if they are at increased risk of developing type 1. After that, they might be eligible to participate in ongoing TrialNet studies. Right now we have 3. There's one that's aimed at people with stage 2 type 1 diabetes using anti-thymoglobulin as the treatment. And then we have 2 additional studies targeted at people with recent onset type 1 diabetes. One is looking at a class of medications called JAK inhibitors. These are immunomodulatory medications that are currently used for alopecia and atopic dermatitis or eczema. And the second study is looking at the use of rituximab and abatacept. Rituximab is an anti-B cell drug and abatacept is an anti-T cell drug. So we're looking at the combination of these 2 to see if we can delay the progression of type 1 over time. We also have a study for people with type 2 diabetes. It's called Precedented. This is funded through the PCORI network. And it's further investigating the use of the newer medications that I mentioned before, the SGLT2 inhibitors and the GLP-1 agonists. We know that both of these classes of medications, as I mentioned, have benefits in terms of cardiovascular and kidney outcomes in people with type 2 diabetes, but we don't really know how they compare to each other. So the goal of this study is to compare the two over the long term in real life situations and see if there's one that is better than the other. I think Rachelle was going to talk a little bit about atypical diabetes. I don't know if we're doing that now or later.
Let's do it now. Let's do it now.
Sure.
And I wonder, Rachelle, if we can start by defining atypical diabetes. Like what
Sure.
does it mean to have atypical diabetes, and what are you all doing and how are you tackling it?
So atypical diabetes is diabetes that doesn't fit a classic definition. It's being recognized more and more in patients who really just don't seem like a type 1 or a type 2. It's very rare. It only accounts for about 2 to 6% of all diabetes in children. And it's found in families that have multiple family members with diabetes. And it is usually explained by a single gene mutation. So it's monogenic forms of diabetes, as compared to type 1 and type 2, which are usually polygenic. There are several genes and gene profiles involved where you have different mutations throughout these different causative genes can have you at increased risk, but these are different. The disease comes from a single gene mutation. And so every child who presents with new onset diabetes, even if they look like a type 2 diabetes patient, gets those antibodies to make sure that they don't have type 1. So if a patient does not test positive for type 1 diabetes antibodies, and they don't fit the typical picture of type 2, they should be screened for atypical diabetes. There are commercial labs that offer testing that can do a panel of genes, things like 25 genes with one blood draw or even a cheek swab. And we are also now actively recruiting patients for a trial called Radiant. Radiant stands for Rare and Atypical Diabetes Network. And this is an NIH-funded trial that really seeks to discover newer genetic forms of diabetes beyond what can be done in a commercial lab. So our doctors, our providers here are really good at finding these patients who may be candidates. And then if they screen negative in the commercial lab, they'll join Radiant and we can learn more.
Yeah. And all really exciting to sort of hear about how you're really treating patients, but also thinking, comprehensively and big picture about where everybody fits or doesn't fit, right? And you're giving them a new bucket to fit into and have therapy tailored to an atypical condition, right? I do want to tackle a couple of questions that have come in, and then we can sort of move on to talking a little bit more about the center that you all are part of, because I think it is very unique in your approach. But let's tackle a couple of these questions. And as a reminder, we're going to leave a couple of minutes at the end for additional questions if we don't get to them now. So feel free to keep sending them. But there's a question that came in, is there ever an indication to check autoantibodies for type 1 diabetes before a diagnosis is made?
Yes. So we're actually trying to write guidelines to let general doctors, maybe doctors out in the community, know when would it be appropriate to check for these autoantibodies. So again, absolutely the first degree family member, but also maybe it makes sense to do it in people who have multiple other autoimmune conditions, because when you have one, it is slightly more likely that you will also have others. So an example would be a child who has celiac disease and thyroid disease.
Right.
Would that be a time to check these autoantibodies? It's a little bit complicated because, as we mentioned, there is a treatment, but it's intensive. And I think it's something that's worth discussing before it's just done in the general population, but that is something we are investigating.
Yeah, yeah. And, we sort of started to talk about this, Jackie, I'll go back to you. But, a follow-up question came in the chat about, are there any studies or is anyone looking at what long COVID can do or the effects on diabetes and really just coming from the observation that a family member really has not been able to get their diabetes under control since, contracting COVID and then suffering from long COVID. So is there any ongoing studies, anything that you know of, any of you, along those lines? And lots to be investigated in that realm. So it's okay if the answer is no.
We don't have any active studies in that area at the Berrie Center. Off the top of my head, I don't know of anything specific going on. It's certainly an area of interest. There was a lot of interest in the interaction between COVID and diabetes type 2 and type 1 during the peak of the pandemic. I think there was a lot of different factors that are very hard to tease apart. And again, we don't have any specific treatments for long COVID or for diabetes in the setting of long COVID, other than that what we use for diabetes in general. But it's certainly an interesting area to consider.
Yeah, of course. And what about, Jackie, the effects of the GLP-1 class of drugs on fatty liver?
So that's also an area that's of great promise. The fatty liver has been one of the more difficult metabolic conditions to treat and can have severe health consequences. And I think we're getting increasing data that shows that use of GLP-1s in people with fatty liver is having good outcomes. So certainly I think that's a work in progress. And I think we're going to see that coming as a real indication in the next few years.
Yeah, yeah. I love that. And we, again, have someone in the audience who is one step ahead of our discussion and just came in with a very timely question. Natasha, let's talk about the center, the Naomi Berrie Diabetes Center, which you lead, the pediatric diabetes program for. You guys have a very unique approach when it comes to children with diabetes. And I wonder if you can share a little bit of that approach and what it is, and also answer the question that just came in, which is, how do you handle transitions of care from pediatric to adults endocrinology to make sure that there's continuity?
Sure. So the Naomi Berrie Diabetes Center was founded in the about 1998 and was founded on the principle of providing the most cutting edge, compassionate care for all people of any background, any economic circumstance who are living with diabetes until we find a cure. We really are a very unique diabetes center. There are actually very few diabetes centers in the United States, and in my opinion, none as special as we are. We really provide the most personalized, accessible care for all of our patients and families, and we want to lessen the burden of living with diabetes in every way possible. So how do we do this? We have an incredible multidisciplinary team who are made up of pediatric and adult doctors, nurses, diabetes educators, and even an art therapist. And we are readily available all hours of the day and night. And we offer care from the very youngest of ages. Our youngest patient right now is 7 months to the oldest, who are people living well into their 80s and beyond with diabetes. And that is actually one of our specialties, is helping patients through life transitions and challenges of living with diabetes. I mean, it is amazing that Rachelle and Jackie and I, we work right next to each other. So when we have patients who are moving from teenage to adulthood, they're actually, Jackie and Rachelle are both running a program, a transition program, to make sure that patients of that age, which are rather vulnerable, are not lost and really well taken care of. We want to help all our teens become the young adults and be a college athlete if that's what they want to do. We have professional musicians. We have so many women living with type 1 who are having babies, and we're caring for all of those women through their pregnancies and postpartum, and really so that everyone can live their best life with diabetes. And in addition, we work side by side in this building with some of the most world-renowned scientists who are doing the work at the Berrie Center to find a cure for this disease. So true bench to bedside research is being carried out right here. I think that makes us really unique and special.
Absolutely. Natasha, can anyone in the community refer to your team?
Absolutely. Absolutely. We take people from our community, we take them from the tri-state area, we take them from all over the country and actually really around the world.
Yeah, yeah. That is amazing, really amazing. And it's such an amazing resource, right? Like even for me as a primary care pediatrician, to be able to refer to you and know that my patients are going to be cared for in the way that you just described, Natasha. Um, I wanted to transition to talking a little bit, and someone just said on the chat, which I think we should read out loud. As a parent of a teenager diagnosed with type 1, I am so grateful to Dr. Leibel and the center. All she's saying is so true. So
Thank you.
a testament to the work that you do, right? And we're so fortunate to have you as a resource in this area, really. I wanted, and this is again a perfect segue to transition to the human side of diabetes, right? And I think you started to get to this, Natasha, and the way that you approach the care for children, teens, adults. And I wonder, as we think about the lifelong toll that diabetes takes on people, what is something that you want people to remember about this lifelong condition, right? And how should we think about this human side for us as physicians, as we see patients, treat patients, guide them on this journey? I guess what are your thoughts on that human side and how to sort of think about it all and keep it in perspective?
Sure. I mean, living with diabetes is not easy, and it is a moment-to-moment disease, and it requires constant attention and constant interaction. And I think the technology and the advances are amazing, but they also are giving constant feedback to people, which I think can be exhausting, and there really is a lot of burnout. But the one thing I would say is that, I've been working as an attending at the center for 20 years, and the changes have been monumental. What it looked like when I started here and what it looks like now are two very different things. And the rapidity of the science today is staggering. And I know it feels slow to the person living with it, but I do believe in the next 20 years, we will make great strides in technology and advances towards a cure. And I am just so inspired every day by the patients and the families I take care of. And I know I speak for the three of us when I'm like, all we want is really to put ourselves out of work.
Yeah, I love that. I'll let you both weigh in as well, Rachelle, Jackie.
I'll go next. So, yeah, I mean, similar to what Natasha said, I'm also inspired by the resiliency of my patients and their families. They simply do not let this disease stand in the way of their dreams for the future. And I see this in so many different ways. I see it in the parents of my toddler patients who are advocating to keep their children in preschool despite not having a nurse on school premises to give insulin. I see it in the school-aged athlete who's reaching out for help to learn about what food and supplements can best fuel them before a game, but not send their blood sugar too high or too low. I see it in my college-aged patients who are away from home and are studying for midterms now, and yet they're still trying to juggle with being independent with their diabetes self-care. So I tell them that by collaborating with us here, both me and my team, making smart choices about food and exercise and taking advantage of the upgrades to diabetes technology, that we can really help achieve all the goals together.
Yeah. Jackie, what about you?
I agree with everything Natasha and Rachelle said. It's an incredible privilege to work with our patients. And this might sound over the top, but I think it's really made me a better person to work here and work with our patients, just to see how life is hard for everyone, but to see how hard it is for people with diabetes. It's, to see the complexity of everyone's lives, to be led into the intimate details of what everyone's going through. It's truly a privilege to work here and to see our patients through all their life's transitions and challenges.
Yeah. So, I love the note of positivity we're on. Definitely send us your questions. We can definitely tackle a few now. Let me just go back and make sure I'm not leaving anybody out. So this is a little bit of outside the scope of what we have discussed, Jackie, I'll pose the question to you, but, all feel free to weigh in. But when it comes to pancreatic transplants, artificial pancreas, where is that field? And again, not, it's not necessarily like something we're going to talk about in depth tonight, but just general thoughts on where we are and where the field is.
So pancreas transplant is something that does happen at our hospital on occasion. It's not common. It's really only offered to people who are also getting a kidney transplant. We're pretty good at transplanting kidneys and maintaining them for many years. We're not very good at transplanting the pancreas. Often they fail, there are more complications. And we sometimes see people back here at our center after they've been off insulin for a period of time following a pancreas transplant, and then the transplant fails. So it's certainly not a panacea. And it's really not recommended for people who aren't getting a kidney transplant, because we have a safe and effective way to manage this disease. It's not easy, but we've been doing it a long time, and we can manage it and prevent complications with the care that we provide. Immunosuppression does have well-known long-term effects. So we would never suggest to somebody that they subject themselves to those risks if we can offer a better way. The hope is that in the future, we'll have stem cells that we could transplant and not require immunosuppression, but we're really a ways away from that.
Yeah, so that gets us to another question that came in about a company called Sana, a stem cell therapy company. It sounds like we're not there yet, Jackie, from what you're talking about. But what are your thoughts on new companies that are coming up? More questions are coming in, so go ahead.
I think all innovation is good, right? So if we have more minds thinking about this problem, the more likely we'll come up with a solution.
Yeah. Natasha, this question that came in, I think is important to tackle in the way that we think about obesity and the risk that it poses for type 2 diabetes. So the question is about, don't most youth who develop type 2 diabetes have severe obesity above the 120th percentile? If that's the case, if that's who mostly develops diabetes, is it fair to say that teens who are overweight only in the 85th to 95th percentile at increased risk for type 2 diabetes? How should we think about that?
It's a good question, and it's very complex. I would say type 2 really runs in families. So even if you have a child who is sort of borderline overweight, but has a very strong family history of type 2, that is a child that should consider being screened. And I believe there are guidelines, for screening by the general pediatrician, when to screen for A1C and so forth. I would not just assume it's going to happen to those who are of the utmost levels of obesity. And I think you have to take a full picture and really look at the family history. I think what we're finding, and again, this goes, scientists here are really working on this. The obesity and diabetes problem is also probably starting in utero with what a fetus is being exposed to in terms of the mother's body type and maybe her risk of diabetes and so forth. And this is one of the issues why we're seeing obesity probably younger and younger, and then even a higher risk of type 2. So it really is a large problem.
Yeah. And I think as a primary care pediatrician, I would add that in my experience, and I think the data supports this, obesity tends to get worse when untreated, right? So unfortunately, sure, maybe risk is low today, but untreated and unaddressed, we know that it unfortunately gets worse. There's a couple of questions that came in from other physicians in terms of just reviewing how infants may present with diabetes, just like the very early presentation of diabetes. Can you just quickly touch on things that we should be always thinking of, signs not to miss when it comes to the very little kids and the way that they present with diabetes? And maybe we'll go to you, Rachelle.
Sure. So there actually is, and when I was talking about atypical, I should have mentioned, there is neonatal diabetes. These are infants that, by definition, this is diabetes that presents younger than 6 months of age. And this is not subtle. These babies present with enormous outputs of urine, soaking through diapers in a way that is just, not typical. And they usually present very sick, and they can develop ketosis and DKA in days rather than in weeks, which is what we typically see with an older child. So it is not subtle. And they arrive in the emergency room looking very sick, and they're usually in diabetic ketoacidosis. We also have our youngest type 1 patient right now is 7 months old. Actually, in the last 6 months, Natasha, we've had about 4 babies older than 6 months, true type 1 diabetes. And they also present with similar symptoms, with polyuria, with soaking through diapers, increasing thirst, just can't get enough of the bottle. And they're dehydrated when they present. And caring for them is challenging. We know some of these babies are still nursing. And so we ask the parents to try and quantify the time on the breast, or the time that how many ounces of milk they're taking, because they still need insulin injection around the time of meals, and they need basal insulin in the background. And we transition many of them to insulin pumps and sensors, of course. And the glucose sensors, I didn't get into more detail about them, but now when a child is wearing a sensor and has a phone that can transmit data to the cloud, then the parents at work, a school nurse in the nurse's office, a babysitter can all be viewing the data on their own personal device. And so that makes caring for these really young children a bit easier. But yeah.
Yeah. What a challenge, right? Like, nursing and feeding, just in general, feeding young kiddos is such a guesstimation at times, right? And what a challenge, and how important to work with you and your team on all of this. There was another question that came in about vaccines and kids that are diagnosed with diabetes. And I wonder if you could address that, but also the bigger picture. Do you think about, preventative care in any different way when it comes to children who are diagnosed with either type 1 or type 2 diabetes? And maybe I'll go to you, Natasha, about that.
So one point I want to make, because I think commonly gets a little confusing, is people with type 1 are not immune compromised. So having an autoimmune disease and being immune compromised are two different things. And people with type 1 who are well controlled, which really try to have our patients be well controlled, but their immune system is going to work just fine. And children with type 1 diabetes are like every other child. They're going to get the normal childhood illnesses and so forth. And really what we recommend is pretty much what the general population is going to get. So we recommend the normal vaccines, the normal routine of vaccines, absolutely. Type 1 diabetes is not caused by vaccines. Also really want to state that.
Yeah.
So I think it's really important to just follow the normal vaccine routine that is recommended. And really today, again, because of the technology and the care and we're not concerned that patients need any extra kind of precautions.
Yeah. I love that. And again, like, as primary care pediatricians, like, we are very closely following and working with a team of endocrinologists to really optimize health and help kids thrive at the end of the day, right? I love this other question that came in. Under what YouTube channel will this recording be, and how can I sign up for these? So just a plug for the Columbia Children's Health YouTube channel. And also we always announce our presentations on social media. So if you want to follow us on Instagram, on Facebook, you will definitely be in the know for when these webinars are happening, and we share the links right on social media as well. And I think I wanted, one very interesting conversation I had with an endocrinologist recently, which sort of left me thinking, and I kind of want to pose the question to you, Jackie, and maybe we can end with this unless another last minute question comes in. But there is sort of this thinking, and she was sort of telling me that these newer medications, right, and the innovation that's going on right now, the GLP-1 agonist, might really change the way that we practice medicine in many ways. And the reason she was making this argument, she said to me, we've built entire fields of medicine to treat complications of diabetes. And I wonder, where do you think we currently are? And do you really think that it is revolutionary and it's going to change the way that we practice and the way that some people like my friend are talking about this? What are your thoughts, Jackie?
So these new drugs are great drugs. We've seen great outcomes with these, but we've only been using them for 10, 15 years at the most. So we don't really have long-term outcomes with these drugs yet. They seem to work. From what we can tell, we know that untreated diabetes has consequences over many years. I couldn't tell you if in 50 years, if you're taking a GLP-1, what might happen, but I know that 50 years of uncontrolled diabetes is going to lead to complications. So, I think these are great drugs. I use them all the time. I don't know that we're at a place where we can say, put everybody on these drugs who has diabetes and we won't see any complications. I don't think that's the case, right? Again, diabetes, type 2 diabetes is heterogeneous, and this is not going to be a fix for every single person. There are people who can't tolerate these medications. There are people who can't pay for these medications. There are people who can't access these medications. If we're talking about treating obesity with a medication, then we'd have to treat 40% of the country with a medication. And I don't think that's at this point something that's feasible. So we're still in the very early stages. All of this is great and promising, but I think we have to still be aware of the progression of diabetes and the long-term effects of uncontrolled diabetes versus these medications.
Yeah. And that's exactly the perspective I was hoping you would give us, Jackie, of like there's a lot of hype and there's a lot of excitement, and some of it seems, rightfully so, but I think, the perspective is just so important. And the reason we have these webinars. So with that, thank you all so much for joining us this evening. We are going to announce very soon our March webinar. As we said, please follow us on social so you're in the know of what we're going to be talking about. It was discussed today, but I can't confirm it yet, but it'll be, there were a lot of questions that came in about this. It'll be very much of interest. I hope you will join us in March. And thank you so much to our panelists for making time this evening to have this super important, enlightening, uplifting conversation. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye, everyone.
Bye.